Thank you. I'm so glad to be back with you guys today. I spoke to this conference about 4 years ago, and since that time, something has changed in my practice. I also have been a victim of the cancel culture. I was a partner in a private gynecologic group for 25 years, but I began speaking more and more, advocating for the life of one of my patients. And apparently, in this society, that is not an appropriate thing to do. The good news is, when I retired, I began working for the Charlotte Lozier Institute. You may not know about the Charlotte Lozier Institute, but I would like to introduce you. We are a think tank that works on science and statistics regarding life issues. If you've ever tried to research abortion, you've quickly discovered, I'm sure, that Google is not pro-life. It'll take you to Guttmacher, it'll take you to Planned Parenthood and other sources, but it will rarely take you to where you can really find good information. Everything we publish is extensively referenced from the peer-reviewed literature, so just wanted to introduce you to our organization. By the way, I do talk fast, and I have always more information to convey than I have time to convey it. So be aware that these slides are in your packet. So if I breeze through something too quickly, you can come back. And also, my email address is there, so if you want to reach out to me individually, you can. So today we're going to talk just generally about what is abortion. We're really going to do a deep dive on chemical abortion. We'll discuss the data deficiencies in this country that make it very, very hard to know what is true. We're also going to discuss the FDA and their prior protocols and their current protocols regarding chemical abortion, abortion pill reversal, and I'm just going to end with a very quick taste of discussion about, you guys have all seen the narratives that states that are protecting unborn life are somehow going to worsen their maternal mortality rates, and that doctors can't intervene to protect the life of the mother. Obviously, those are lies, but we'll just touch on those briefly. So we all know that contraception is an action that is taken prior to the act of intercourse with the intent of preventing that unborn life from beginning. And usually this is hormonally by stopping ovulation, or a barrier method that keeps the egg and the sperm from getting together. Emergency contraception has the same intent. It is after the act of intercourse, but Plan B, the most popular method, is will work to delay ovulation, to prevent that egg from being available. So sometimes people get confused. Plan B is not a chemical abortion. An abortion is an action that is taken when that new life is known to exist, and its intent is to end that life. This can be done either mechanically through surgical means or pharmaceutically, as we'll discuss today. I have the best job. I don't know if there's any other obstetricians here, but I love both of my patients, and I absolutely adore the early human life. It's incredibly complex. 23 days after that life begins, electrical impulses are powering the cardiac muscle to contract, propelling oxygenated blood throughout that child's body. That is a heartbeat by anybody's definition. Very quickly, we see arms, legs, mouth, nose, ears. By the end of the 6th week, he has all of his internal organs. And at that point, his name changes. He becomes a fetus, same person, just a different developmental phase. We can see fingerprints, we can see fingernails, and at 10 weeks gestation, if we pay attention on an ultrasound, we can determine if he's right or left-handed based on the thumb that he prefers to suck. So obviously, one of my patients, a life of infinite value, his life is ended with every abortion. But it also harms my other patient. 1 in 4 American women are estimated to have had an abortion. At least 1 in 5 American men have been the father of an aborted child. When surveyed, only 7 to 14% of obstetricians say that they would perform an elective abortion if requested. So this narrative that it's between a woman and a doctor, false. That it's necessary health care, false. If it were necessary, every obstetrician would provide that intervention. And so we struggle, as I know everybody here struggles, with what is the role of a physician? Do we make an individualized recommendation based on our knowledge of a specific patient and based on our experience? Or do we follow a vending machine model, give the patient what she wants, as Dr. Cotello so eloquently expressed, even if we know it's going to harm them. No, of course we should not do that. Chemical abortion, the regimen approved by the FDA is 2 drugs, Mifepristone, its brand name is Mifeprex, its French name is RU486, which you may have heard, blocks progesterone receptors, so it cuts off the hormonal support and ends the embryonic or fetal life. It's followed in about 24 hours by Mifepristone or Cytotec that induces contractions to expel the pregnancy tissue. It's a terrible experience for women. Almost every woman will experience almost all of the side effects that I've noted here in blue. The average woman will bleed for almost 2 weeks. 8% will bleed for longer than a month. 40% of these women describe the pain as severe, and they should, because essentially their body is in labor. And so many times these women will see the child that they have chosen to abort. So as you see the pictures in the subsequent slides, just recall, the woman is seeing this in her toilet. The process of approval, it turns out, was highly politicized by the FDA. So we have another drug to add to Andy Shafley's list last night of FDA malfeasance, Mifepristone. They redefined pregnancy as a life-threatening illness so that they could approve it rapidly through their accelerated approval regulations in the waning days of President Clinton's administration. They have never performed the studies they are required by law to do on a pediatric population, even though there is no lower age limit when girls can take these drugs. They initially approved it only up to 7 weeks gestation. The provider had to be a physician who specifically registered to get access to this drug. It was dispensed directly to the patient, who needed to be warned about the risk of serious side effects. Complication reporting was mandated, as were 3 visits. It was governed under a risk evaluation and mitigation strategy, or REMS, which is one way that the FDA tries to supervise the use of a dangerous drug. In order to get access to these drugs, or to Mifeprex specifically, the doctor has to confirm that he will accurately determine the gestational age, that he will rule out an ectopic pregnancy, and that if it fails, he will intervene surgically or have an agreement with someone else who can do that. Mifepristone is more widely available. It's used for other indications like peptic ulcer disease, so it does not have a REMS, but Mifepristone does. In 2016, under President Obama, the FDA approved a supplemental application that extended the use to 10 weeks gestational age, even though they knew the failures were higher in the higher gestational age. At that time, they said the provider no longer had to be a physician, even though, of course, only a physician is going to have the surgical skills to deal with the complications. They also said that they no longer wanted to hear about complications unless it killed the woman, and they decided that a follow-up visit was unnecessary. They approved a generic in 2019, but it gets worse. In 2021, using the COVID pandemic as an excuse, the FDA permanently removed all the in-person requirements. This means face-to-face counseling, labs, physical examination, ultrasound are no longer required. They pointed to studies that actually utilized ultrasound in order to say that an ultrasound was not necessary. Earlier this year, they began allowing it to be distributed through brick-and-mortar pharmacies. This means women can order these pills by telemedicine, by online ordering. These are distributed in the mail, often illegally, and through pharmacies without any medical supervision in many cases. And we see that chemical abortion use is increasing. Women are being steered toward this. They're told it's natural, they can have an abortion in the comfort of their own home, that it's safer than Tylenol or penicillin. But what do we really know? In this country, there is nothing on a federal level that is mandatory about abortion data collection. The states will report their numbers of abortions to the CDC, but some, like California and Maryland, that do a tremendous number of abortions, don't bother to report any data. The Guttmacher Institute gets their information directly from abortion providers. They consistently report far more abortions. Only about half of the states have laws on the books requiring complication reporting from the abortionist. Far fewer require other doctors who care for women to report complications. But there are few enforcement mechanisms or penalties for noncompliance. So essentially, the abortionists report their complications if they feel like it. Maternal mortality data is even worse. The CDC gets most of their data regarding maternal deaths from death certificates, but there are many reasons that death certificates often do not record an abortion. A maternal death is any time during pregnancy, at the time of the end of the pregnancy, and all the way up to a year after the pregnancy ends. So we can see that like a mental health death caused by an abortion is very, very unlikely to ever be detected by the CDC. Scandinavian countries have far better data. They have single-payer health care that pays for elective abortions, but you can do records linkage and subsequently discover what's really going on. In Finland, when they looked at this question, they documented that nearly 19 out of 20 women who died in relationship to an abortion, the abortion was not listed on the death certificate. So it just goes to show how poor quality CDC maternal mortality data on this issue is, only the tip of the iceberg. And by the way, that question about abortion safer than Tylenol or penicillin, that's comparing the vastly underreported deaths from abortion to the Tylenol overdose deaths and to the anaphylactic shock deaths in our country. Obviously, a very dishonest comparison. As just one example of how the pro-abortion medical organizations paint this issue to promote abortion is this 2018 booklet from the National Academies of Sciences, Engineering, and Medicine. They concluded, among other things, that serious complications or long-term physical or mental health effects of abortion are virtually non-existent, that no special equipment or emergency arrangements are required for chemical abortions, and that abortion is so safe that the only deterrent to its safety is legislative restrictions that prevent a woman from accessing abortion immediately. But when we look behind the curtain, we discover this was a very biased study. It was funded by 6 outspoken abortion advocacy organizations. They did do an extensive literature review, but then they subsequently got rid of most of the studies, said they were defective. They cherry-picked data from fellow abortion advocacy researchers. As an example, there were less than 5 studies on which they based their conclusion that there was no long impact concerning breast cancer, concerning mental health complications, and concerning preterm birth, when for each of those topics there were between 75 and 160 peer-reviewed studies available, the majority of which showed a positive correlation. We know that mifepristone can directly increase the risk of hemorrhage by interfering with the contraction of the uterine vessels. We know that it will not work on a pregnancy that is implanted outside of the uterus, an ectopic pregnancy. It doesn't do a very good job of expelling the dead tissue. That's why it has to be used with Mifepristone. But even so, there's frequent retained dead tissue, and this can predispose to hemorrhage as well. Both of these drugs can suppress the immune system, increasing the risk of infection. And again, when there's dead tissue present, that worsens that risk. Half of the deaths that have been associated with this combination have been due to overwhelming sepsis in normal, healthy women. Mifepristone carries a black box warning, which of course is FDA's strongest warning. They warn providers that a woman can have an atypical presentation of a serious infection without a fever, without an elevated white blood cell count, or without significant pelvic pain. They also warn them that they may bleed, and the only way to resolve the bleeding is through surgery. Their warning label also warns providers to rule out an ectopic pregnancy and to test a woman's blood type to see if she would benefit from a RhoGAM injection to prevent future pregnancy complications. The FDA collected complication data, but it never published it for 16 years. So some pro-life researchers filed a FOIA request to get access to the data, and they published it. They determined that there had been 3,800 complications reported. But over that time period, there were estimated 3.7 million chemical abortions. Even if we said a low estimate is 2% complications, we should have expected 74,000 reports. So it appears that the abortionist, again, usually did not report the complications, with less than 5% of the complications actually being reported to the FDA. This data did show that when surgery was required, it was usually provided by someone other than the abortion provider. This is the data looking at it another way. The gray bar is the mandatory reporting to the FDA. The orange bar is the FDA's adverse events reporting system that the public can report to. And the blue bar is a study that was published by Planned Parenthood over these 2 years, documenting that complications are very low. So they reported far more than the FDA knew about, but even so, they called it low. And clearly, it looks like Planned Parenthood did not report all of their complications to the FDA, even though mandated. So how do we get better data? We look at systematic reviews. This is good because you're looking at all the available data. The downside to this is that so many of these studies have large numbers of women lost to follow-up whose outcomes are unknown. These were performed by abortion advocacy researchers, but even so, when they looked at all of the studies and didn't cherry pick, they found between 3.4 and 4.8% of the women required surgery after a chemical abortion. At Lozier, we were able to perform a records linkage study in the United States. 17 states will use their state Medicaid dollars to pay for elective eugenic abortions in the Medicaid population. Actually, I jumped ahead. Here we go. This is ours, and I'll go back. So we looked at over 400,000 abortions in a 15-year period of time and discovered that within a month, 5% of these women came to an emergency room with a complication, and even after a surgical abortion, 2% came to the emergency room with a complication. And when we dug into it deeper, we discovered that 60% of the time they were miscoded as having been due to a miscarriage. So I'll back up to the one I forgot. This is European records linkage data. Finland, very, very high quality data. 42,000 early abortions. They discovered that 6% after chemical abortion required surgery and 2% after surgical required surgery, another surgery. When they compared first and second trimester abortions, 10% in the first trimester, almost 40% in the second trimester required surgery. And this graph demonstrates that the complications were 4 times as frequent after a chemical abortion, affecting 1 out of 5 women. So going back to that miscoded data, why would that happen? I think a lot of doctors in the emergency room don't ask the question. They just assume that it was a miscarriage. Women are embarrassed. They don't want to talk about it. And they're actually being told by abortion providers to lie to doctors. They say that they can't tell the difference between a miscarriage and a chemical abortion and that the treatment is not different, so it doesn't make any difference. But that's not true. A follow-up study from the Lozier data documented that the women who had been miscoded as having a miscarriage when in fact they'd had a chemical abortion averaged 3 visits in the emergency room before they finally got the surgical treatment that they needed. The New York Times, of course, loves to promote abortion. They published a lengthy article about how safe it is. They quoted a Planned Parenthood doctor saying, surgeries following failed chemical abortion are no more risky than if you had a surgical procedure from the beginning. I think we can all recognize that's not true. Emotionally, these women often bleed for a long time. This lack of resolution is difficult. Physically, they're suffering. They're bleeding and in pain. I've cared for women as much as 2 months after the abortion that have bled every day before they finally sought care. And usually this is due to retained tissue. So this dead tissue in the uterus, particularly if it gets infected, can lead to intrauterine scar tissue. This can cause infertility. This can cause future pregnancy complications. And so obviously that's a concern. A large Chinese study documented that if a woman starts with a chemical abortion and ends up having a surgical completion, that her risk of preterm birth is much higher. In fact, extremely preterm birth, less than 32 weeks, was almost 3-fold higher in these women. And of course, we can see this is going to negatively impact our healthcare system. Our ERs are already overworked and overstressed, and if 5 to 6% of women are presenting after chemical abortions, this is only going to worsen that problem. Obviously, this has financial implications, as well as, I continue to work part-time as an obstetric hospitalist, so I'm covering a labor and delivery and covering an emergency room, and I've seen these women. So I have to bump scheduled surgical cases to take them to the OR emergently. Sometimes I have to call in the OR team in the middle of the night. And because I'm covering L&D as well, maybe I even have to call in the backup physician because I can't be two places at once. So I think it's clear who benefits and who does not benefit from chemical abortion. In 2020, it was estimated there were over 500,000 abortions, chemical abortions in our country. With those failure rates that I reported earlier, we would expect between 17 and almost 50,000 women yearly to need surgery in emergent circumstances. Why don't you hear about it? These women are ashamed. They just want the situation to be over. They don't want to talk about it. They don't want to sue. In fact, I've had them tell me, Dr. Skop, I think this is what I deserved for making the decision I did. So very traumatic, and they're living in shame. Obviously, many benefits to the abortion industry. Primarily right now, we're seeing them use these drugs to circumvent state laws where the states are trying to protect life. It's lucrative. They don't have to pay a surgeon. They don't even have to find a surgeon. Very few obstetricians want to do abortions, even though so many of them say they're pro-choice, but they don't want to get their hands dirty with the killing. Obviously, it's very traumatic for these women. We've discussed that. And then she sees her child. So then she has this very difficult decision. What do? Do I flush him? Do I put him in the trash? Do I take him out back and bury him? And many of these women do bury their child in their backyard. So here we are. Like I told you, it's worse than previous because now these chemical coat hangers are widely available all over our country without medical supervision. So how can this additionally harm women? Well, these women are ordering these pills without ultrasound, right? So they're being asked to estimate their own gestational age, and sometimes they get it wrong. They may be a month further along than they thought, and as I documented, the complications and the failure rates are much higher the more tissue there is to be resolved. No one's ruling out an ectopic pregnancy before they give these pills. So ectopics are not uncommon. About 1 in 50 pregnancies are implanted in the fallopian tube. These drugs don't work there. It can continue to grow. It can rupture the tube, leading to catastrophic bleeding and maternal deaths. No one's doing labs. 15% of women have Rh-negative blood, and they need RhoGAM to prevent a future immune response against their future children, which can be quite serious. We're not treating sexually transmitted infections concurrent with the abortions. We're not screening for anemia. We're not obtaining informed consent. And we don't even know who's ordering the drugs. Is it a woman who wants an abortion or a sex trafficker, incestuous abuser, or coercive boyfriend? We don't know the risk because we don't know the numbers of complications. There are 3,000 crisis pregnancy centers in our country that want to walk alongside women and support them. But of course, they don't know that that alternative exists when they order it from a chemical abortion website. Again, no provider relationship. Self-managed abortion used to be a bad thing prior to Roe, but apparently today it's a good thing for the abortion industry. The REMS is still in place. That means that I can't prescribe these drugs. A doctor has to take the initiative to register, but of course there's strong pressure on the FDA to get rid of the REMS. If that happens, every women's health care professional is going to be encouraged by their professional organizations to prescribe these pills, not just obstetricians, internal medicine, pediatrics, family practice. You've probably all seen this in your literature. They're amping up to tell you need to provide this service. Mental health complications. It turns out in the rat model that mifepristone all by itself increases the animal proxies for depression and anxiety. Several meta-analyses have documented increased depression, anxiety, alcohol and substance abuse, and self-harm after abortion. And these, of course, can lead to deaths of despair, suicide, homicide, accidental deaths, and overdoses. The APA has acknowledged that there are subgroups of women that are at much higher risk for mental health complications, those who are pressured or abort a pregnancy that they wanted, those with prior mental health issues, prior abortions, and late abortions, as well as some other factors. Many times abortion advocates will acknowledge that sometimes women have mental health complications, but they'll say, you know what, it wasn't the abortion, it was these women, they're in really rough situations, it was the situation. So at Lozier, we looked at that 17-state Medicaid data that I mentioned earlier, the records linkage, and looked at women who aborted their first pregnancy versus those who carried that pregnancy to term. The women who aborted, we discovered, were twice as likely to have an outpatient mental health visit afterwards, almost 3 times as likely to experience a hospitalization for mental health, and they had 7 times the length of or the number of days stay. We looked at the women's mental health prior to the pregnancy and discovered that actually the women who ended up giving birth had higher mental health problems prior. So this blows that narrative out of the water. Abortion most definitely causes mental health complications. I have to go fast because I'm running out of time, but Turnaway study, you may or may not have heard about it. Essentially, very, very the selection bias was incredible. Over 100,000 abortions they could have chosen from. They approached 3,000 women. About 1,000 said that they would participate. Half of those dropped out over the length of the study. So that study population, that cohort, was not representative of all women. And there are many other problems with the study as well. Dr. Dave Reardon at Lozier has published data about unwanted abortions. 60% of women surveyed said that there was high degree of pressure on them to abort. Only a third described the abortion as wanted. A quarter said it was unwanted or coerced, and 43% said they accepted it because of their circumstance, but it was inconsistent with their values. And 60% said they would have preferred to give birth if they had just had more support. You may not know about the Alliance for Hippocratic Medicine versus FDA lawsuit. You'll hear probably more from Donna Harrison tonight. But this is pro-life medical groups suing the FDA because they're not doing their job, which is to protect women from dangerous drugs. The judge in the Amarillo court agreed with us. The Fifth Circuit agreed with us. The Fifth Circuit said that the Mifepristone should go back to its initial conditions of approval, and this has been appealed to the Supreme Court. So here we are. These pills are everywhere, right? The Washington Post did a sympathetic portrayal of an abortionist in New York who on her ping pong table was putting together packets to mail into places like Texas. And she says, really without any sort of remorse or worry at all, Texas might say I'm breaking their laws, but I don't live in Texas. And it's true. These very pro-abortion states have passed shield laws protecting their abortionists who are breaking the law to provide abortions in pro-life states. No extradition, no malpractice, no wrongful death lawsuits, no loss of license, no loss of malpractice. And of course, the ultimate goal is over-the-counter with no medical supervision ever. And I think we all recognize what this means. These women are having their abortions alone at home, very traumatic, under coercion sometimes. When they have complications, they've got to figure it out. Where do I go? And then what do I do with my baby's body? The abortion industry has already told us what they're going to do if they lose access to mifepristone. They're going to promote misoprostol rather than return to surgical abortions, which are safer. And misoprostol alone fails in 1 out of 4 women requiring surgery. Abortion pill reversal is an option. Why? I think we all know. Women are coerced. They change their minds. This works exactly the same way that Narcan for an opioid overdose works. The mifepristone is blocking the progesterone receptor, so high-dose progesterone can outcompete and in many cases keep the pregnancy going. And literature supports this, both animal studies, a retrospective study documented that 2/3 of the women who used the most appropriate progesterone protocols were able to continue to have a living child. It's safe. We use it all the time like candy in pregnancy. No increase in birth defects. It's used off-label, but we all know that doesn't mean anything, and the FDA is never going to study progesterone for this indication. But we see that the pro-abortion medical organizations have proven to us they're not pro-choice, they're pro-abortion because they don't want women to have this choice. ACOG has called it unproven and unethical. AMA has called it contrary to science. Dr. Delgado, who pioneered this technique, has been slandered beyond belief. Colorado's passed a law saying that this is deceptive advertising, and the Colorado Medical Board has already said they will discipline physicians who provide this. California's followed suit. So that's it for chemical abortion. I have 2 minutes left, so I'm going to jump over to what has happened in the wake of Dobbs, when now the states can protect unborn life in their states. There have been 3 reactions, as we've discussed. Chemical abortion has really been the linchpin. Judicial activism, every single state has been sued, and fear-mongering. Making the public, pregnant women, doctors afraid of these laws is a large part of the opposition. And you've seen these articles, I think. Doctors have an impossible choice. They can't provide adequate care because of pro-life laws. 25 states have laws protecting life. As you can see here, the ones in yellow are still working to defend their laws in court, so it has been a struggle for some of these states. An attorney and I looked at every single one of those laws. Every law allows an exception if an abortion is needed to protect a woman's life or to prevent a serious risk to her health. So the reality is doctors don't have to compromise the way they treat. They can continue to treat women the way they always have. And as I mentioned earlier, 90% of obstetricians do not do elective abortions. And just the final slide, when we look at that good quality Scandinavian data, we discover that following an abortion, a woman is 2 to 4 times as likely to die of any cause within that year, 6 to 7 times as likely to commit suicide, 2 to 4 times as likely to die from an accident, and 10 to 14 times as likely to be murdered. So giving birth obviously protects women. Having an abortion harms them. And so thank you. If you're interested in the topic of maternal mortality, we've got quite a bit of information on our website about that as well. So thank you for your attention.